I'm very happy to be back in my country finally, and I'm gonna speak today. Actually, I'm gonna skim the subject of imaging infection because it takes longer time, but I'm gonna skim focusing on the changes that happens in the strategy of imaging and localizing infection since last time we presented this, or we were discussing this a few years ago. I'm going to start with very brief basics. Many of us, and even of course others, always think of cancer and diabetes, cardiovascular disease. Infection is as serious as those important conditions, but it actually costs more than these diseases. Costs for individuals, for institutions, for the societies. And the problem is, it has been a dilemma since it was first reported at the time of pharaohs. And it is still with us, emerging and re-emerging new microorganisms, and including viruses, and the corona is one of the examples. And actually, this year, 2025, I just read from the report on CDC, 13,000 were killed by infection in the US, and a huge number are admitted to the hospital and so on. So it's very important to tackle the problem of infection and find out how can we diagnose and localize the infection in the most cost-effective and prompt way. Now, the imaging in general is dependent on understanding the changes that happened with inflammation and the infection, but particularly the vascular changes, and more importantly, the cellular changes, including the chemotaxis, including the hypoxia, cytokines, as well as the glucose metabolisms. All of these are very connected to the choice of the imaging procedure and related to the future invention of new radiopharmaceuticals, because as you will see, we have a very long list of radiopharmaceuticals for infection, which means none of them is ideal for infection still, and we still have a way, or a long way, to go to find out more ideal agents. The infection, as you know, is acute or chronic. The acute infection may resolve, or it may cause abscess and spread. It can be organized, and it can lead to chronic infection. And I mention this basic just because I want to emphasize on the active chronic infection. And we will find the value of this understanding when we talk after a few minutes about the chronic active skeletal infection, because the chronic inflammation or infection by itself may not be bothersome. It may not be serious at all. But the chronic active, it needs a different attitude in the management. Now, the diagnosis of infection, of course, the clinical and the signs and symptoms, laboratory and imaging. The problem of the lab is the non-specificity. So combining, and I again would like to mention the word that I love, the holistic. When you look, even imaging or pathologists, imaging specialists or pathologists, when you look at a case, you have to look at it holistically. So when you look at the clinical signs and symptoms, detailed history, as well as the lab, you still have a significant percentage of cases of suspected infection that need imaging. And when we talk about imaging, we will divide this talk to soft tissue infections and the skeletal infections. For the soft tissue infections, we must, from the start, to determine what we are going to use, which is my main aim of this presentation, is to find which imaging modality is suitable for a certain situation. If there are localizing signs, so we know the location or the possible location, then the morphologic imaging is the way to go. And this includes, of course, the ultrasound, more importantly, the CT and the MRI. And if these functioning morphologic modalities are not conclusive, then comes the functional modalities or the scintigraphic modalities. And this include the labeled white blood cells, which is still the most specific for acute infection. But still, you may need something else, even with this highly specific modality, because in certain situations it will not work. And I will detail that. So gallium-67 is still in use, particularly if the most important modality is not available, which is the FDG PET-CT. So the labeled white blood cells is difficult, tedious, and it takes time, but the FDG and the other PET-CT procedures are very efficient. Time-wise, you finish in a couple of hours. It has a very high negative predictive value. And when it is positive, not only it indicates or it points to the location as well as the pathologic process, but also it guides the further management to the patient. Now, if there are no localizing signs, then the strategy will be the opposite. We start with the functional modalities to screen the entire body to find out where is the infection and try to diagnose it. And recently, actually, the whole body MRI has been introduced, but not yet prevalent as I understand. Now, the radiopharmaceuticals are being extended for infection, and particularly the new radiopharmaceuticals being investigated, and actually some are used, including the biotin, including the gallium-68, of course, FDG, and labeled actually white blood cell with FDG, and phyluridine also. Now, again, as I mentioned, if no localizing signs, you use white blood cells, and it can be useful also in monitoring the progress of the disease, and again, gallium-67, and most importantly, the FDG, as I mentioned, when localizing signs are there. When no localizing signs are present, this includes a fever of unknown etiology, which have a lot of causes, and it's a dilemma for the managing physician, because it's not only caused by infection, but it can cause by non-infectious inflammatory, as well as neoplasms and the other causes, including even the psychological status. And the workup is complicated, and it includes the imaging, of course, modalities, and the most important of which are the nuclear medicine, particularly the FDG PET-CT. Now, here are some examples of the FDG PET for the fever of unknown etiology, and these are actual cases. This case detects uptake in the vertebra as well as the surrounding soft tissue. This case is a case of infective endocarditis, and you will hear a specialized presentation about this subject, and this is a case of COVID-19. Now, here is the algorithms. When we have a suspected soft tissue infection, if there are localizing signs, go for morphologic modalities. And these have a lot of advantages, particularly the time, the resolution, which is way much better than the scintigraphic procedures, unless you have a SPECT CT or a PET-CT, or in other words, a component of the SPECT with it. In addition, it guides treatment as aspiration. If the morphologic modalities are not conclusive, we have to ask ourselves, localizing signs or no localizing signs. If there are, we have to ask ourselves about the duration. Because if the duration is short, in other words, acute, use the FDG. If the FDG is not available or difficult to use, then if it is acute, you have to go for labeled white blood cells and live with its disadvantages, because it is a definitive procedure with very high specificity for the acute. If it is more than 2 weeks or longer duration, it means that it's going to be or towards chronicity, and the chronicity means the inflammatory cells will be different, will be mononuclear cells, plasma cells, macrophages, and this will cause or may cause false negative labeled white blood cell results. So it is not reliable. And in this case, the very important application of FDG, but if not available, then you have to go for the basic gallium-67, or if you have gallium-68. In any case of these, if the morphologic modalities are definite, we are done. But if you need any explanation, you can add later on the the functional modalities. And the opposite is true. If you find the site of infection and you need further details such as the details of the tissue and the extension and so on, you can seek an additional morphologic modality for this soft tissue infection. Now, for skeletal infection, and this is a repetition, but I will remind you, the skeletal infection is not synonymous for osteomyelitis, because it can be just infectious periostitis, osteitis, or osteomyelitis when it involves the bone and the bone marrow. And this is important, again, I always say, because you may see trivial changes, and we shouldn't ignore it, particularly in the pediatric age group, depending on the stage or the type of skeletal infection. Now, of course, we use both the morphologic modality and the functional modalities. One of the changes that happened in the last 10 years or so is that the MRI is the first modality of choice. Of course, after the plain X-ray, which is always the bread and butter, or the first modality that we use in any skeletal or suspected skeletal abnormality. But after that, if it is not conclusive, which is common, or you may also use a quick ultrasound, both of these don't have a high yield of diagnostic or conclusive conclusion. So the first after that is the MRI, not the bone scan, not any other, because it doesn't expose the patient, particularly in pediatric age group, to radiation, and it has a very adequate accuracy in identifying the skeletal infection. And here are examples, the X-ray, ultrasound, and CT showing a Brody's abscess here, and a CT showing gas in one of the vertebrae. So if you use even CT for whatever reason, we have to be aware of the issue of emphysematous osteomyelitis. Emphysematous osteomyelitis is rare, but it's a serious disease. The mortality has been reported to be up to 45%, but most of the people, or most of the studies, are reporting in the 30s. And we need to be aware when we read SPECT CT and when we read PET CT of the presence of, or possible presence of emphysematous osteomyelitis if we see gas in particular vertebra, which is the common site and the serious site of the emphysematous infection, which is caused by gas-forming microorganisms. That's why it shows gas in the vertebra, or intraosseous gas. MRI, as I mentioned, is the current recommendation. So if MRI is equivocal, or if it is not available, or if the patient cannot tolerate it, or it's contraindicated for whatever reason, then we go for functional imaging. And these functional imaging, again, include a long list of procedures, and which means also we have to tailor our strategy according to the situation. And bone scan is still, and I hope it is the case here, it is still a viable and important procedure in the practice of nuclear medicine. And when the patient has no prior, particularly no prior skeletal pathology, the bone scan has a very good accuracy for the diagnosis of a skeletal infection in the proper clinical setup. And you have to be aware that the osteomyelitis can be the classic one with focally increased flow, blood pool, and delayed uptake, and it can be cold, which is more aggressive, so we have to be aware of this and be careful. SPECT-CT or in general, all the hybrid procedures are very important in diagnosing infections in general, but particularly in the bones, because many times you will not be able to locate the abnormality properly and even to separate it from the soft tissue nearby. One of the important findings in bone scan is the infective arthritis or septic arthritis, infectious arthritis. And the most important feature here is periarticular distribution, and this periarticular should be confined to the capsule of the joint. If it is outside, it means that there is additionally some sort of skeletal infection. And this is different from the cellulitis, which will have flow and blood pool abnormalities, but it should clear or relieve some hyperemic changes, and if you even image later on, it will disappear. And also different from bursitis, which does not show periarticular or the features of infectious arthritis, not periarticular, not confined to the joint capsule as a whole. And this one, it can occur in a part of the joint area. Now, remember I told you about the chronic active infection, and here is a case of chronic osteomyelitis, and this is white blood cell, which is essentially negative. Does this exclude chronic active skeletal infection? No, because here is another case, and I like to show this case, which essentially is positive in bone scan. I don't see the the arrow here. In the bone scan, it's positive, and white blood cells is negative, and the gallium-67 is positive because the duration is 6 weeks, and which means that it's a chronic, and the white blood cell may show false negative result. So when you have a suspected chronic active osteomyelitis, actually the FDG, as I mentioned from the outset, it can diagnose the acute and the chronic infections, and it's actually extremely important for chronic active osteomyelitis. And if it is not available, then we go for the gallium-67, not the labeled white blood cells. And this is an example of a case of a chronic active osteomyelitis under Brody's abscess here with FDG. Now, for the spondylodiscitis, or what we call vertebral osteomyelitis, although I prefer the spondylodiscitis because discitis is almost always associated with the vertebral osteomyelitis. And the bone scan, and as you see in this case, is not really helpful in this case. And the MRI here, it shows clearly the abnormality in actually this is an 11 months old baby. I believe it was a young baby. Anyway, and here is another MRI which shows clearly the abnormality with very good resolution, and actually it shows it has a very high accuracy for vertebral osteomyelitis or the spondylodiscitis. FDG is a modality of choice for of the the scintigraphic procedures. As we talked about, the chronic active skeletal infection, it's applicable in the spondylodiscitis because also it's a kind of chronic infection because of the delayed diagnosis. And here is a recent collection for the comparison of the different modalities of imaging in vertebral osteomyelitis, and you can see the MRI has a high sensitivity and the specificity, as well as the PET FDG. And if the PET is not available, the other alternative would be, in my opinion, the combined the bone and the gallium, not the gallium only, and it has to be SPECT CT, and it gives a very comparable accuracy. Diabetic foot, we'll start again with MRI. If MRI is not conclusive, then we go for the combined bone, white blood cells, and if labeled white blood cells are only positive, then we add the sulfur colloid and we diagnose the condition. If the findings of the sulfur colloid is not matching what we see on white blood cell. And here is the example. Here is a diabetic foot, and you can see two areas of uptake here. And the white blood cells, this is the bone. White blood cells show also, again, the two spots, but only one has matching or congruent bone marrow uptake, which means that this is not infection, but this one in the heel is an example of infection. So when white blood cell is positive, we do the sulfur colloid to find out whether this accumulation of labeled white blood cell is due to the bone marrow uptake. Someone will tell me bone marrow in the foot is not normal. Yes, it's not all normal, but the pathology will cause altered bone marrow due to reactivation of some cell islands remaining from the time of conversion of red to yellow bone marrow at the peripheral location. Now, the same concept is going to be applicable as in diabetes for the periprosthetic and the post-traumatic. This is a violated bone by definition, and the bone scan only will not be sufficient, and we have to do in addition labeled white blood cells, and if positive we add the bone marrow. Now, we come to the algorithm for skeletal infection. As we mentioned, X-ray is a routine. And here someone may ask, if it has a low, relatively low accuracy, why do we do it? One is, it may give the diagnosis with the least expensive and the fast way. If not, it will add information, whether previous disease, whether the bone is violated or not, and whether there is additional abnormalities that may explain findings in other modalities. So it's a must. Now, if the X-ray is inconclusive, which is common, very common, then we go for MRI. This is a new, established now procedure or concept. If it is diagnostic, we are done. If it is not conclusive or contraindicated, blah, 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 we see if the location of suspected infection is non-vertebral or vertebral. For the non-vertebral, we will do the bone scan. And if it is negative, we are done because it has, and any actually, or most of the scintigraphic procedures, they have a very high negative predictive value with the exception of labeled white blood cell. If we talk about acute infection, still it's applicable, but for chronic infection, it doesn't have a high negative predictive value. And if it is positive, if the bone is virgin, not violated, it's enough to make the diagnosis, including the neonatal osteomyelitis. Previously, they were questioning the accuracy of bone scan in neonatal osteomyelitis, and they would say repeated or do gallium and so on. But the newer data contradicted this because the data were old from the time of old instrumentation. And if the bone is violated, like in diabetes, post-traumatic, and so on, you do white blood cell, and if positive, you add sulfur colloid, and of course, FDG. FDG for acute and chronic is important. Now, for the vertebral location, FDG, if the MRI is not conclusive, you do FDG. Only if it is not available, you can seek gallium-67. And in conclusion, We have to always understand and re-emphasize the benefits and the limitations of different imaging modalities in correlation with the pathophysiologic features of different infections, whether soft tissue or skeletal. Now, very important and expanded role of MRI in infections in general, particularly skeletal infection. Hybrid imaging, as I mentioned, not the planar. PET-CT has expanded and it has an important role in infection, particularly fever of unknown etiology, which actually some people call it the gold standard or the gold modality for the fever of unknown origin. Infective endocarditis, and you will hear that. Chest infections, chronic active osteomyelitis, always the first thing to think about is the FDG and the spondylodiscitis. In some countries or areas, if the FDG PET-CT is not available, then we go for gallium-67. Still, after all of this and the refinement, we have a long way to go to improve the diagnosis or the definite diagnosis and localization of infection. And I have a small book about infection and inflammation by multimodality imaging. I'm going to call Dr. Hosna I will give this to you for the people, if they can, my colleagues, if they want to copy or use. And then I'm going to call Dr. Walid Omar, my chief. I want you to come, please. I'm going to thank you very much for your role. And here is a small token for you. These are two of the new books that came this month and last month out of the National Institute of Cancer in Cairo University, published by Springer, and giving this to Dr. Walid, the head of the nuclear medicine in the institute. Thank you very much.